Policy ideas often gain and lose popularity over time, and this applies to policies related to the major healthcare programs of Medicare, Medicaid, and the Affordable Care Act as well. In the Medicare Rights Center series, What's at Stake?, we break down some reform ideas and how they could affect the coverage, care, and outcomes for older adults and people with disabilities. It's important to note that these are not partisan policies, and different lawmakers have championed these ideas at different times. Now, this video is one of two that will unpack what's at stake with Medicare, Medicaid, and the ACA. Here, we'll focus on Medicare-specific challenges. As a reminder, Medicare is a federal program that provides health care to adults age 65 and over and younger people with disabilities. Anyone who qualifies is entitled to the same set of standard benefits, though the costs might vary a bit based on whether they enroll in Original Medicare or a Medicare Advantage plan. The first thing to keep in mind is that Medicare and other public health care programs can tangle people up in a lot of red tape. Burdensome enrollment paperwork, lack of information, administrative backlogs, and confusing timelines are just a handful of the hurdles people may face. And the more programs someone is relying on, the more these issues multiply. To fix this overly complicated landscape, Medicare Rights supports measures that lessen confusion and streamline access, including using existing data to enroll people in programs that they qualify for, like Medicare savings programs, and, when it comes to Medicaid, rolling back work reporting requirements. Over the years, policymakers have suggested changing the way Medicare works in ways that could undermine coverage and care. These ideas are often presented as cost-saving strategies, but this framing is both disingenuous and inaccurate. Let's dig into those threats, starting with eligibility. Problems with raising the Medicare eligibility age. Medicare is nearly universal for the 65-plus population, but some lawmakers have argued that as Americans live longer and delay retirement, why not raise the eligibility age by a couple of years or more? Denying people Medicare eligibility at 65 doesn't save on healthcare costs and disproportionately harms some people, like those who perform manual labor and others who often must retire earlier and in poorer health than their office-working peers. Without Medicare at age 65, these workers would likely go without necessary care, leaving them in worse health when they finally do get to join Medicare. This higher acuity would drive up the cost of their care, increasing Medicare spending and individual beneficiary expenses. In the current system, the pool of younger, healthier beneficiaries also keeps costs down. Problems with means testing Medicare. Means testing, which in this context is the process of factoring in income to determine what benefits someone is eligible for, is another potential cost-cutting strategy some policymakers have suggested. But means testing Medicare would cut and limit coverage. This is a deeply unpopular policy. Medicare is a promise waiting for working Americans, and restricting benefits based on income erodes that. It is also administratively complex. In addition to coverage barriers and operational hurdles, tiering income could create arbitrary cliffs, where a few dollars can mean the difference between access to care and no care at all. Proponents of means testing largely forget or ignore that higher earners already pay more into Medicare through higher payroll taxes while they are working and through the Income-Related Monthly Adjustment Amount, or IRMA, once enrolled in Medicare. Means testing threatens Medicare's universality, which workers spend years paying into. Other proposals would change costs and payment. Problems with private contracting. Under the current system, there are 3 types of relationships providers can have with Medicare that determine whether they accept Medicare payments at all, and if so, how much. Most accept the amount Medicare sets as full payment, and they can't charge patients above that amount. Under private contracting proposals, however, this framework would not apply and providers would get more leeway at the expense of their patients. For example, providers would have the right to charge beneficiaries more than is currently allowed, either by requiring their Medicare patients to negotiate a contract for their care or by simply charging a higher amount. Without the cost protections of the current system, people with Medicare could be priced out of care, especially in rural areas and places where provider options are limited. Problems with converting Medicare to a voucher program. Another proposal would turn Medicare into a premium support system, aka a voucher program or defined contribution system. Instead of Medicare existing as a standard set of benefits, people would be given a set amount of money to purchase coverage. While the specifics of that amount and the calculations behind it vary from proposal to proposal, all shift significant expenses onto people with Medicare without guaranteeing access to the benefits they have today. Problems with rolling back improvements in the Inflation Reduction Act. Prescription drug affordability is a major issue for many Americans, especially older adults and people with disabilities. Among other important changes, the Inflation Reduction Act of 2022 finally brought popular drug price negotiation to Medicare in a first step toward lowering drug costs. But some lawmakers want to reverse course, and some damage has already been done. The 2025 Budget Reconciliation Bill, H.R. 1, narrowed the already limited negotiation program. This will result in $5 billion more in Medicare spending, higher costs for beneficiaries, and reduced drug access. These descriptions are just the tip of the iceberg when it comes to potential Medicare policy changes. For in-depth analysis, visit www.medicarerights.org/policy.